Over to the last session of our CBS. So, second degree AV block, distinguishing the Morbitz type 1 from Morbitz type 2. Haven't we done that before? Okay, let's do it. So, firstly, we'll talk about the level of block. Okay, give me a second. Yes, so here you go. We were talking about the level of block. So, in Morbitz type 1, it is usually the AV node. The ECG finding will show progressive prolonged PR interval, leads to non-conducted PUS, that is group beating. The QRS complex will be narrow. Exercise or atropine improve the type 1 AV block. It is very important because the reverse is true for type 2. So exercise will improve the type 1 AV block. Now let's try to make sense out of that, because listen, the problem is with the AV node. When we do the exercise or when we give the atropine, the parasympathetic system goes down and sympathetic nervous system goes up. When sympathetic nervous system is upregulated, you may say, so that will lead to increased conduction of impulses through the AV node, and that improves the type 1 morbid type 1 heart block. Vagal maneuvers or carotid sinus massage worsens the type 1, because the problem is with the AV node. So when we stimulate the parasympathetic system, which physiologically decrease the AV conduction, so the type 1 block worsens. Risk of complete heart block, there is a low risk of that. Now, morbid type 2, the level of block is below the level of AV node, for example, bundle of His. ECG findings that PR interval remain constant with intermittent non-conducted P waves. The QRS complex can be narrow or wide. Now, this makes sense, right? So the reverse is true for morbid type 2. I don't think that I would be able to make some adequate logic for that, but it is logical that retropine or exercise improves type 1 AV block and vagal maneuvers decrease it. So the reverse is true for type 2. That exercise or retropine worsens the type 2 AV block. In vagal maneuvers, they paradoxically improve the type 2 AV blockage. The risk of complete heart block, there is a higher risk, and that is an indication of pacemaker as well. Then atrioventricular block, I think we have done this table, but let's do it again. Morbid type 1 second degree block. I'm sorry, first degree people, the people with first degree heart block are asymptomatic. ECG findings, PR interval prolongation, and management is observation. Morbid type 1 or second degree people are usually asymptomatic, and ECG features include progressive PR interval lengthening followed by dropped QRS complexes. The treatment is observation. Rarely, PPM placement. What is that? Um, some kind of pacemaker, maybe. Okay, then morbid type 2 second degree, fatigue, lightheadedness, and syncope are the presenting complaints. There will be constant PR interval with a random drop QRS complexes and PPM pacemaker. Okay, permanent pacemaker. Okay, so PPM is a permanent pacemaker placement, is the treatment of choice for morbid type 2, and we can do that in morbid type 1 if indicated. And third degree or complete heart block, fatigue, lightheadedness, and syncope is the symptom. Complete dissociation of P waves and QRS complexes, and permanent pacemaker placement is the treatment of choice. Complete AV block means that atria are beating separately and ventricles are beating separately. It's third degree heart block. Complete failure of impulse conduction from the atria to the ventricles. The PP intervals are constant. Some P waves are hidden inside the QRS complexes, and the RR wave intervals are constant. That an escape rhythm is established, independent conduction from the ventricle. So escape rhythm means, like, it's a very easy concept, that normally SA node, which is the pacemaker with the highest rhythmicity of 60 to 100 beats per minute, is the main pacemaker, and the other pacemakers, other potential pacemakers like the AV node, the bundle of phase bundle branches, and the Purkinje fibers, they remain quiescent because of the dominance of this one. When due to some pathology, the connection between the SA node and the AV node or the atria and ventricle is broken down, now there is a chance for other pacemakers to come out of the dominance of the SA node, and they attain a new rhythm of their own, that is the escape rhythm. So the atria will be contracting under sinus stimulation, and the ventricles will be stimulated by some pacemaker in the ventricles, most predominantly the AV node. So here you can see that these are the escape rhythms. The P waves are hidden in the QRS complexes. The P to P interval is constant, and the R to R interval is also constant. It is complete block of AV node. This can lead to ventricular arrhythmias or asystole. The management is immediate temporary pacemaker. The detailed evaluation is carried out for reversible causes such as MI, increased vagal tone, metabolic disturbances like hypokalemia, and AV nodal blocking agents. If no reversible cause is found, a permanent pacemaker is the indication. EKG, actually ECG and EKG are synonyms. I just got to know that, so never get confused on that again. EKG finding is a complete David block. There is a complete failure of atrial impulses to capture the ventricular QRS. Unless an escape rhythm is initiated, ventricular asystole, syncope or death will occur. The escape rhythm QRS can be narrow, junctional escape or wide, that is ventricular escape. The P wave has no relation to the QRS complexes, complete AV dissociation is present, and ventricular rate is always slower than the atrial rate, that is usually less than 50. So the ventricular rate will be less than 50. ECG changes in hyperkalemia. Hyperkalemia is associated with hyperacute T waves, right? So the PR interval will be prolonged. Then tall peaked T waves will be present. If the potassium level is 6 to 7 milligram, normally it is 4.5 to 5.5 ish. But if it is 6 to 7, then this will come to in the image. If it is 7 to 8, so loss of P wave, ST elevation with tall peaked T waves. And if it is more than 8, then widened QRS, sinus wave pattern, AV nodal block, fascicles and beta blockers. Fascicles and bundle branch blocks will be seen. Then comes the sick sinus syndrome. Degeneration of the cardiac conduction system with fibrosis of the SA node and surrounding atrial myocardium due to aging is the most common cause that leads to impaired SA node automaticity, and that will lead to sick sinus syndrome. Other causes are ischemia and infiltrative cardiac disease. The presentation is fatigue, lightheadedness, palpitation, presyncope, and syncope. ECG will present with bradycardia, sinus pauses and arrest, SA exit block, alternating bradycardia and atrial tachyarrhythmias, tachycardia bradycardia syndrome will be present. On ECG with the sick sinus syndrome, we find both of these things. That is, tachycardia bradycardia syndrome. There is no ECG for that, but the problem basically is that there are, I'm just trying the QRS complexes. There are bradycardic events which are associated with pause, and then comes a tachycardic event. It does not look like that. I'm just, I have a bad cursor, and then comes bradycardia again. So this is bradycardia tachycardia syndrome that is characteristic of the ECG of a sick sinus syndrome. Okay, then moving forward, it may show chronotropic incompetency, indicate heart rate response to the exercise. Complications include atrial fibrillation due to fibrosis of the atria. The treatment is pacemaker and rate control medications for persistent paroxysmal tachyarrhythmias. The clinical features of sick sinus syndrome are as follows. Elderly patients, bradycardia like fatigue, dyspnea, dizziness, and syncope. Bradycardia tachycardia syndrome, atrial arrhythmia, for example, atrial fibrillation and palpitations. ECG findings include sinus bradycardia, sinus pauses, delayed P waves, and sinoatrial nodal exit block, that is dropped P waves. Treatment is with a pacemaker with or without rate control medication if there are tachyarrhythmias. Amyloidosis. The etiology is that extracellular deposition of insoluble protein fibrils. AL amyloidosis produced by the clonal plasma cells. A amyloidosis produced chronic secondary to chronic inflammation. ATTR it is abnormal transthyretin protein something. So it is age related or familial. It is amyloid transthyretin protein or amyloid beta 2 microglobulin. It is associated second with hemodialysis, so it is like secondary to the hemodialysis. Clinical presentation: asymptomatic proteinuria or nephrotic syndrome, hepatomegaly and macroglosia, cardiomyopathy usually restrictive, peripheral autonomic neuropathy, waxy skin thickening, and easy bruising. Diagnosis is tissue biopsy, for example, abdominal fat pad. It can cause multi-system disease due to fibril deposition in the tissues. Cardiac amyloidosis. It is a form of restrictive cardiomyopathy. It is an important cause of heart failure with the preserved ejection fraction. Etiology is idiopathic, infiltrative disease like sarcoidosis and amyloidosis, storage diseases like hemochromatosis or endomyocardial fibrosis. It should be suspected if a patient presents with finding of congestive heart failure with echocardiographic finding of concentric left ventricular hypertrophy and non-dilated left ventricular cavity in the absence of a history of hypertension. Features include right heart failure symptoms are predominant. Atrial enlargement is common. Cardiac conduction abnormalities may occur. The diagnosis is endomyocardial biopsy. Biopsy of other tissues like abdominal fat pad can also be done. Other features of amyloidosis: asymptomatic proteinuria, for example, more than 300 milligrams per day. Nephrotic syndrome, more than 3.5 grams per day of urinary protein loss may also be seen. Waxy skin, anemia, easy bruising with ecchymosis and thrombocytopenia. Hepatomegaly, GIT bleeding, early satiety, subcutaneous nodules, enlarged tongue, and peripheral autonomic neuropathy. These are the features. The clinical manifestations of amyloidosis, either primary or secondary, are like there is a multi-system disorder, so there will be renal, cardiac, CNS, GIT, pulmonary, musculoskeletal, skin, and hematological problems. In the kidney, heavy proteinuria with nephrotic syndrome and peripheral edema. The cardiac complications include restrictive cardiomyopathy, conduction defects, and low voltage. CNS will present with the peripheral or autonomic neuropathy and stroke. The GI complications include hepatomegaly, dysmotility, and malabsorption. GI bleeding due to vascular fragility. Pulmonary complications are pulmonary nodules, tracheobronchial infiltration, and pleural effusion. The musculoskeletal problems include enlarged tongue, shoulder pad enlargement. The skin problems are thickening of the skin, subcutaneous nodules or plaques, ecchymosis, and periorbital purpura. And hematological problems are anemia and thrombocytopenia. Amyloidosis classification. The primary amyloidosis disease association like multiple myeloma and Waldenstone macroglobulinemia. The precursor protein is Ig light chains. I have to zoom it in, I guess. So the precursor proteins are Ig light chains. Misfolded mechanism is increased production, and amyloid fibril type is AL amyloid. Secondary amyloidosis, the disease association is chronic infection or inflammation. The precursor protein is serum amyloid A. Misfolding mechanism is increased production, and amyloid fibril type is AA amyloid. Organs affected include kidney, liver, spleen, heart, peripheral nerves, tongue, and skin. Dialysis related disease association is end stage renal disease and dialysis for more than 5 years. Precursor protein is beta 2 microglobulin. The misfolding mechanism is decreased clearance. In these two areas, primary and secondary amyloidosis, the mechanism was increased production, but for the dialysis related beta 2 microglobulin, the mechanism is decreased clearance. And amyloid fibril type is A beta 2 microglobulin. Organs affected are ligaments, carpal tunnel syndrome, shoulder joint bone. Hereditary senile causes disease association is autosomal dominant inheritance with age-related deposition. Precursor protein is transthyretin, that is pre-albumin. Mechanism is mutation or aging, and amyloid fibril is ATTR-M and ATTR-WT. So ATTR-M means amyloid transthyretin mutated, and ATTR-WT means amyloid transthyretin wild type. Both of them can be the amyloid type in hereditary senile amyloidosis, and organ affected include heart, peripheral nerves, and ligaments. Amyloid name begins with A, followed by the precursor protein abbreviation like AA is amyloid, AA amyloid, A beta microglobulin. We'll talk about that one forward. Sarcoidosis. It is associated with a cardiac non-caseating granulomas. It should be suspected in any young patient aged less than 55 with unexplained second or third degree heart block. Any patient with known or suspected systemic sarcoidosis with ECG changes. The presentation is complete AV block due to infiltration of non-caseating granulomas into the conduction system. Restrictive cardiomyopathy, early manifestation. Dilated cardiomyopathy is a late manifestation. Valvular dysfunction and heart failure. Inferior vena cava thrombosis, the features are lower extremity edema, ascites, and decreased or normal jugular venous pressure. Carotid artery stenosis. The risk factors are hypertension, prior smoking, diabetes, and obesity. The types include asymptomatic and symptomatic. Symptomatic is defined by the occurrence of transient ischemic attack or stroke in the distribution of affected artery within previous 6 months. Do not consider lightheadedness, syncope, or vertigo as part of the carotid stenosis manifestations. The carotid stenosis does not present with any with these symptoms. Diagnosis is duplex ultrasonography of the neck. Management. All the patients with carotid artery stenosis should be given antiplatelet and statin therapy. Symptomatic patients. The carotid end arterectomy is recommended for symptomatic patients with high-grade carotid stenosis like 70 to 99%. In asymptomatic patients, low grade, less than 80% stenosis, lesion should be managed medically. CEA, carotid end arterectomy, may be beneficial for those with 80 to 99% stenosis. Carotid end arterectomy is preferred over carotid artery stenting because stenting is associated with increased risk of stroke and peri-procedural mortality risk because there will be stent thrombosis, and that because of close proximity of the carotid arteries to the cerebral circulation, there is an increased chance of stroke with that. Excessive alcohol intake. It is defined as binge drinking more than 5 drinks in a row for more than 2 drinks per day in males and more than 1 drink per day in females. It is associated with increased incidence of hypertension. Benefits and risk of alcohol consumption. So, moderate definition. Moderate or steady alcohol consumption means women less than 2 drinks per day and men less than 3 drinks per day. Possibly increase blood pressure, decrease the cardiac events and total mortality, increase the insulin sensitivity and improved glucose metabolism. Heavy or intermittent alcohol consumption is when women more than 7 drinks per week or 3 drinks at a time, men more than 14 drinks per week or 4 drinks at a time. And binge drinking means women more than 4 drinks at a time and men more than 5 drinks at a time. Increase in blood pressure, cardiac events, risk of stroke and total mortality, increased risk of atrial fibrillation and dilated cardiomyopathy, increased risk of accidents and trauma, unstable glucose level, potentially severe hypoglycemia in patients taking sulfonylureas, increased risk of cirrhosis, acute and chronic pancreatitis. What is pacemaker syndrome? Some patients with significantly prolonged PR and first degree AV block may develop this syndrome. The presentation is uncomfortable awareness of heartbeat, that is palpitations, due to atria contracting against the closed mitral valve during the ventricular systole. Treatment is pacemaker. Then GERD. Although it is a topic of GID, but basically GERD can mimic the chest pain of angina, so that is why we are discussing it here. The pathophysiology is decreased tone or excessive transient relaxation of lower esophageal sphincter, anatomic destruction of the gastroesophageal junction, for example, hiatal hernia, increased risk of obesity, pregnancy, smoking, and alcohol intake. Manifestations are regurgitation of acidic material in the mouth, that is called as acid brash. There will be heartburn. Podynophagia often indicates reflux esophagitis. Extraesophageal manifestations include cough, hoarseness, and wheezing. The complications are esophageal erosive esophagitis, Barrett esophagus, strictures. Extraesophageal complications include asthma and laryngitis. The initial treatment of lifestyle, for example, weight loss and dietary changes, and H2 receptor blockers or proton pump inhibitor. Management: patients with fewer than 2 episodes of symptoms per week. Lifestyle changes like weight loss, head of bed elevation, and H2 receptor antagonists. Patients with more frequent or severe symptoms, evidence of erosive esophagitis or laryngopharyngeal involvement, we should start an 8 weeks course of proton pump inhibitors. Fibromuscular dysplasia is a disease of relatively young women who present with hypertension, so that can be a secondary etiology and secondary cause of renal artery stenosis. It is a non-inflammatory and non-atherosclerotic condition caused by abnormal cell development in the arterial wall that can lead to vessel stenosis, aneurysm, or dissection. It most commonly affects the women 15 to 50 years of age. It can involve any artery, but most commonly involve a renal artery, then carotid and vertebral artery. Presentation is hypertension, amaurosis fugax, if it involves carotid artery, carotid bruit, heart below the mandible angle, headache, pulsatile tinnitus, dizziness and brain ischemia because and that's TIA and stroke. Fibromuscular dysplasia decreases the kidney perfusion, leading to the increased renin and aldosterone level that will lead to secondary hyperaldosteronism. Aldosterone to renin ratio is 10. Uh, Aldosterone to renin ratio will be equal to 10 or less than 20. Okay. So, like, what does that even mean? Okay, the diagnosis is non-invasive, CT scan and duplex ultrasound. These are the non-invasive tests, and the invasive tests are catheter-based digital subtraction arteriography. That is invasive. Catheter-based digital subtraction arteriography. Moving forward, we have clinical features of fibromuscular dysplasia. The patients to screen are women aged less than 50 with one of the following. Number one is severe or resistant hypertension. Onset of hypertension before age of 35. Sudden increase in blood pressure from baseline. Increase in creatinine more than 0.5 to 1 mg per deciliter after starting the angiotensin converting enzyme inhibitor or angiotensin receptor blocker and without significant effect on the blood pressure. And systolic diastolic epigastric bruit. The clinical presentation is resistant hypertension from the renal artery involvement. Cerebrovascular fibromuscular disease with symptoms of brain ischemia like amaurosis fugax, Horner syndrome, and transient ischemic attack and stroke. Non-specific symptoms of headache, pulsatile tinnitus, dizziness from carotid or vertebral artery involvement can also involve the iliac, subclavian, and visceral arteries. Diagnosis and follow-up. Non-invasive testing is preferred like CT, angiography, and duplex ultrasound. Catheter-based digital subtraction arteriography for the patient with inconclusive non-invasive testing. Medically treated patients need follow-up blood pressure and creatinine every 3 to 4 months and renal ultrasound every 6 to 12 months. The calcium channel blocker associated edema. Peripheral edema is common side effect of CCP's mechanism. Calcium channel blocker cause precapillary arteriolar dilation. This leads to increased capillary hydrostatic pressure and fluid extravasation into the interstitium. This effect can be countered by using the combination of calcium channel blockers and ACE inhibitors. ACE inhibitors cause post-capillary venodilation and hence decreased capillary hydrostatic pressure, thus lowering the risk of peripheral edema caused by the calcium channel blockers. Hyponatremia in the congestive heart failure. It is due to decreased perfusion of kidneys leading to increased renin, increased norepinephrine, and increased ADH. The treatment is fluid restriction, ACE inhibitors, and loop diuretics. Necrobiosis diabeticorum. It is a skin condition frequently seen in the patient with diabetes, as you can see here. Although it is rare, but necrobiopsy like vertical diverticorum is associated with diabetes and can be seen. Skin lesions precede the onset of diabetes. The skin lesions typically occur in the pretibial areas. Features of skin lesions are multifocal, brownish hue, dilated blood vessels, and central epidermal atrophy. Then comes the drugs that affect the phosphorus metabolism. So phosphorus with acetaminophen can prolong the INR, and if the INR is prolonged, that can result in increased bleeding. Several factors can change the phosphorus metabolism. Firstly, the dietary changes. Eating vitamin K-rich foods like spinach and Brussels sprouts may lead to decreased phosphorus activity due to replenishment of vitamin K in the body. Patients should be advised to maintain a steady intake of food rich in vitamin K. The new medications are as follows. Starting new medication which affects cytochrome P450 metabolism can affect the warfarin metabolism as well. Other medications can affect the warfarin metabolism through different mechanisms like antibiotics. They reduce the bacterial vitamin K production in the gut, so that will worsen the effect of warfarin. Acetaminophen more than 2 to 3 grams per day, they interrupt the vitamin K recycling in the liver, which leads to increased INR. Drug supplements that affect the warfarin metabolism, cytochrome P450 inhibitors, increase the warfarin effect and increase the bleeding risk. Acetaminophen and NSAIDs, antibiotics, antifungals, for example, metronidazole, amiodarone, cimetidine, cranberry juice, ginkgo, biloba, and vitamin E, omeprazole, thyroid hormones, SSRIs, and fluoxetine. Cytochrome P450 inducer decrease the warfarin effect and decrease in efficacy. Carbamazepine and phenytoin, ginseng, St. John's wort, oral contraceptives, phenobarbital, and rifampin. So these are the sketches from the sketchy pharma. So this is amiodarone, this is cimetidine, and these are the azoles. All of them are inhibitors of cytochrome P450, and thus they can increase the level of cytochrome P450 level in the body. So drug supplementation that affect the warfarin metabolism selected. Cytochrome P450 inhibitors increase warfarin effect and increase bleeding risks. Antibiotics, for example, metronidazole and macrolides. Azole antifungals building crushing the car. So basically, these are sketchy mnemonics. You just go to the sketch to know the mnemonics. Amiodarone, cimetidine, and grapefruit juice. These are cytochrome P450 inhibitors and thus increase the warfarin effect and increase the risk of bleeding. Cytochrome P450 inducers decrease the warfarin effect and decrease in efficacy like carbamazepine, phenytoin, phenobarbital, rifampin, and St. John's wort. The next thing is chronic venous stenosis. The risk factors are obesity, advanced age, varicose veins, and history of DVT. The clinical features include leg pain, that is achy and heavy legs, edema, venous dilation, varicosities, and telangiectasias, dermatitis, erythema, pruritus, and scaling and weeping, ulcers, chronic body indulation and brown discoloration, and ulcers. The management is elevation and compression stocking. So here you can see in the picture, these are chronic venous stenosis can lead to ulcer formation like this, and when to initiate warfarin, first heparin is infused into the patient, and when PDT is more than 1.5 to 2 times the normal, then it is safe to initiate warfarin, and we are done with the CVS. Until next time, Allah Hafiz, fi amanillah, and take care.